Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Hey everyone, welcome back to Cracking Cancer. Today we're continuing our discussion with Dr. Allie Mungo and Samantha Murrell about surgical resections in patients with stage 4 cancers.
Can you talk a little bit about the location of the primary tumor? I have some people who friends at stage 4 who have locations of their primary tumor are perhaps not in the best places, which makes surgery riskier. Can you talk a little bit about that?
Yeah, absolutely. So when we think of lung surgery, again, the goal is to get out all of the tumor. I would say the most common lung surgery that's done is a lobectomy. Again, there are 3 lobes on the right side. There are 2 lobes on the left side. In order to do a lobectomy, most of the time we're able to do it with small incisions in a minimally invasive fashion. Here, I use the robot a lot, but there are surgeons who use the robot, surgeons who don't use the robot, and the non-robotic way is called VATS. And in terms of the size of the surgery, a lobectomy is an anatomic operation. You literally do all of the dissection so you can expose the arteries that feed the lobe, the veins that feed the lobe or vein, and then the airway that feeds the lobe. And that's tedious. That's where we really get into the stickiness that we were talking about before, because when you're dissecting on those areas, that's oftentimes where the cancer cells and or the lymph nodes are that have had such a robust response to treatment. And so if I can safely do a lobectomy for somebody with stage 4 disease, or sometimes even less than a lobectomy, meaning a segmentectomy where I take an anatomic piece of the lobe pie, or maybe even a wedge resection where I don't do all of the dissection on the structures and I just take a normal swath of tissue around where the nodule or tumor is. Those are things that I think are good operations for stage 4 disease. There is a lot of scientific debate about whether you need to do an anatomic lung resection for someone who has stage 4 disease versus less. And you will hear surgeons arguing about what to do for oligometastatic disease. So I think that there is still some work to be done in terms of trials as to what proves to be better. But I will tell you, as someone with a science background, when we do a lobectomy, we do take many, many more lymph nodes. We already know in our stage 4 patients that there's probably cancer in the lymph nodes. So I'm not sure that physically removing nodes that don't light up hot on PET provides you more longer term survival or disease-free interval. I just don't really know the answer to that. So going back to the original question of like what surgery is the right size of surgery for somebody who has stage 4 disease, I think that a pneumonectomy or removing the entire lung on one side is a really big thing to do in anyone, and especially somebody who has metastatic disease. Now, you may say, why would you do that? Why would you have to take out the entire lung? You know, I think that most lung cancers are like this big. It's like a golf ball. Well, sometimes they're bigger, and sometimes they're really close to the center of the lung, like right where the lung meets the heart. In those situations, the only way to take out the tumor would be to take out the entire lobe. And especially, or the entire lung, excuse me. And especially if the tumor is attached to some of the main arteries or veins that leave your heart, then I don't think surgery is the right idea, even if it's just in one spot.
Samantha, I'm curious to hear, you're well connected, at least in the thoracic, community for patients with lung cancer. Are patients going around to a lot of different institutions and trying to find different surgeons who are willing to do these surgeries?
I think a lot of people are going to their oncologists and asking their opinion on surgery. And I think a lot of those oncologists are telling them no. And then people get frustrated. And then they try and find surgeons outside of their local network that they might be able to speak to. Because I think a lot of times they think if their local oncologist says no, the local surgeon is also going to be on board with that opinion. So then they tend to go further afield. But then it becomes a lack of resources, money, insurance, all of these things that are potentially blocking that individual from just getting on a plane and getting a major surgery done in a completely different state. I mean, it's a whole nother animal. I was very fortunate that I could get it done locally, 30 minutes away from me. I can't imagine having to fly on a plane, a couple weeks later to get home. And then if there's complications, what happens, So a lot of people are going further afield, but they have all of those blockades up against them when they do that.
Yeah, and maybe speaking a little more to that, like Allie, when would you recommend someone be able to fly after this kind of surgery if they have to travel to get this done?
Yeah, so generally speaking, I would say if you came to me from out of the state, which honestly happens a reasonable amount in Colorado because there are quite a few states around us that don't have major cancer centers. Mm-hmm. So as far as traveling home after lung surgery, whether it's for cancer or not, most of the time we tell people to stay locally for about a week. And then afterwards you can fly. There was previously some question about when people can fly and the risk of pneumothorax and things like that. But I think it's generally pretty safe to fly about 5 days after surgery. And there's no magic number there. It's just mostly that I want to make sure that you've had several days out of the hospital with stability, that somebody sees an x-ray and we don't see your lung dropping or fluid accumulating in any, large degree. And once we're all comfortable with that, then you can go. There's no magic number.
And are these surgeries that you're considering doing? I think if someone's out there hearing the podcast and they have a lung cancer, something in the thorax, the chest, are you someone who evaluates these?
Yeah, I absolutely am. And I would say, not just for me, but, if you're looking at seeing any surgeon, go see a surgeon that is part of an NCI designated cancer center where you really have people who are working in clinical trials, who are apprised of the most current information. And that's important from both the surgery side, but also the medical oncology side and the radiation oncology side, because you want a group of people that work together. Lung cancer treatment does not happen in a silo. You need to work together as a big team. And that's how we end up getting to decisions to do surgery on people who have metastatic disease.
Well, building off what you were saying, people who specifically do that, I think there's a perception out there, particularly when it comes to surgery or radiation, that a surgery is a surgery is a surgery. And yeah, so when people see me in medical oncology, a lot of times it's for a second opinion. And I recommend a therapy or whatever, whatever I recommend usually can be done elsewhere just fine. Mm-hmm. The recommendation is what I offer. It's my perspective. It's my, the scientific background I have. But the surgeon, they're the technical person who's doing the thing. So that's usually when I say that's when you need to come back to someone who really does these and has an expertise in these. So yeah, I think going to a trained person who does that specific type of surgery ends up being more important.
Obviously, I am very biased, but if I had a cancer, I would want to see, and this is not just about me, this is about any thoracic surgeon or any specialist surgeon for whatever type of primary cancer you have. You should be operated on by somebody who does the type of surgery that you are receiving every week, because their outcomes will be better. Their familiarity with the problem and the anatomy will be better. And if anything goes wrong, which, sometimes it does, then they're in a setting where they have all of the surrounding structures and other subspecialists who can help us overcome whatever the problem is. So I think that cancer surgeries most of the time should be done in centers that pretty much specifically do that.
Yeah. And
not just for lung.
Well, and I say that too for family members and other people who have advised for any type of cancer care. I usually say get established at the place that you would go if something bad happens. Where would you want to be if things do go downhill? Start there. You can always like de-escalate and start getting your therapy someplace more convenient once things are ironed out. But in the beginning and during these high-risk times, when a surgery is a high-risk time, no doubt about it, you want to be at the place that knows what they're doing, at least specifically to your case.
Now, this does kind of go back to something that Samantha said about what if I live somewhere where there isn't a center like this close to me, and this could potentially cause a really big hurdle for me, both financially, family members coming, where do I stay after surgery? And that's true. That is all true. So these are all kind of the pluses and minuses of this. We take care of people who live in really rural parts of Wyoming, for example. It's like one of the closest states to us. And that can be really hard on people's families. But I would still say that if it was me or my family member having a cancer surgery, I would go somewhere where they do it all the time if I could.
Mm-hmm.
Well, Samantha, you did that.
Yes.
Yeah, you lived in rural Wyoming specifically.
Well, rural Montana.
Montana, sorry.
Yeah, yeah.
Sorry to the WAMI region. Yeah. So, and you relocated largely because you had to get cancer care at a, National Cancer Institution designated center.
And sometimes it's not possible for people. Like sometimes people don't have the resources. So I guess another thing to say is that sometimes in these more rural, far away areas, sometimes you could even ask for a virtual second opinion at places too.
Yeah, those things, the social workers can be really helpful to figure out how can we bridge a gap of costs. But no, I think these are questions we're going to have to iron out better as we're doing more of these. And I think one thing that is really important, you were mentioning multidisciplinary teams, is finding teams that work well together. Like Allie and I work very well together. We've been on multidisciplinary tumor boards before. We talk about these patients together. So it's nice to go to a team where you have a medical oncologist, the surgeons all talking together about how can we best, have the systemic therapies that go everywhere, do the surgeries, and then we make sure that, okay, we've cut out the things that we can see and we're treating the things we can't see adequately, that this all makes sense together. Luckily here, we also have a lot of research going on, which is something that you had mentioned was an appeal to your group. And for us, it gives us the opportunity to learn about the tumors that we're cutting out. Mm-hmm. What are the new things that we can target on them? How can we best treat these tumors? And does it give us a sense of what's going on in the places we can't see? So it helps us push the field forward if these are done at academic centers too. And that's something we've discussed, and hopefully, that influences people who do want to contribute to the research of lung cancer. That is a way to do it. It's a way that is a lot of burden on the patient because they are undergoing a surgery and everything. But, we want to utilize whatever opportunities we have to push the field forward. And undeniably, that is one.
So Kyle, what advice do you have for someone whose oncologist might be very against surgery, but the individual believes they're a candidate? Should they get a second opinion?
Yeah, with us. If you have lung cancer. No, you should. You should, because this is a situation where, as I've said in other contexts, reasonable minds may differ. There's not a clear right answer to a lot of this stuff. And people who are apprehensive to do it because they haven't had a lot of experience with it are probably right to be apprehensive. You need a real team that's come together, that's done this before. And even then, do we know for sure that it's the best idea? We don't know yet. Right. We're doing it, and these are in research centers usually that are able to follow these patients over time, put together the data, make an assessment. Was this a good decision?
In highly selected patients.
Yeah.
People who are the super fits, the super youngs, the super limited disease sites.
Yeah. So I think the second opinion absolutely makes sense. And then, if you're at a center that does these kinds of surgeries, but they're not sure you're a great candidate, meaning maybe the tumor is too spread, maybe the physical activity needs to be better, you can, take those sentiments to another group and say, hey, they thought this, what do you think? And then, professionals can talk. So I think the more people do that, probably the faster the field's going to move and how we cumulatively view this situation, because it is brand new. So the second opinion is absolutely critical, and don't feel guilty about that. We don't mind as providers if someone chooses someone else's recommendation over ours. Everyone's just doing their best. We're all trying to help the patient the best we can. We're all just people in this together. And ultimately, it's the patient that has to live with the consequences of their decisions, whether they decide to do a surgery or not. There's consequences to both. And no one has to experience that other than you. And we get that, we get that. It doesn't bother us. So that's what I would recommend.
Totally agree. I'm always happy when people get a second opinion, because I think it makes you feel more confident in your choice going forward.
Yep.
And you mentioned getting other opinions with oncologists. How did that change your perspective? I
didn't get opinions on surgery necessarily with the second opinions with different oncologists, but it reassured me I was on the right track, or I wasn't on the right track with other things. So it definitely made a difference to me. The surgery thing was my own endeavor that didn't involve getting second opinions. I just kind of ran with it.
Well, and this is one thing I've noticed is you tend to get one opinion if it agrees with what you want to do.
Oh, 100%.
You don't tend to get a second opinion saying, I want surgery. They said, yes. What do you think? That's a pretty rare occurrence.
That's a study in human nature.
Yeah. But, I do want to get in a little bit to the side effects of surgery. It's not trivial, and we can speak probably more to lung because that's what you do.
True.
And that's what you got. And that's what I'm closer to. I don't do lung surgeries, but maybe Samantha, we'll start with your experience. What was getting the surgery like, and how has your recovery been?
Well, I don't know what the surgery was like because I was asleep.
You slept through it. Perfect.
I slept through it. I had some crazy dreams.
Too easy.
And I don't remember any of the dreams, but I just remember them being crazy. I woke up in ICU. They put you in ICU first. I don't know if that's normal everywhere, but here they do. I had a breathing apparatus on, and they kept giving me this, almost like a nebulizer thing on a regular basis, some kind of steroid or something, and a hell of a lot of pain medication. And I honestly was in zero pain. It was pretty amazing. My only issue coming around from surgery was I was extremely nauseous from the anesthesia. I knew that was going to happen. I told them about it. They were prepared, but no medication touched it. So I was vomiting up a storm, which was a great experience. But otherwise, being in no pain was amazing. I'm not saying that's going to be the case for everyone, but mine was very much managed on something called Dilaudid, which I've never had before. So maybe that's why it works so well. They tried to do an epidural on me 3 times and it failed. Apparently that's never happened ever to them. So I'm a new case study there on being able to get an epidural, but they used Dilaudid and it worked fine. And I honestly didn't have any pain the entire time I was in hospital. I was taken out of ICU within 24 hours, taken off oxygen within a couple of hours. So my turnaround was pretty quick. I was I confused some of the nurses because when I was moved into this secondary room that wasn't ICU, I kept sitting by the window looking out at the mountains, and they were expecting me to be in this hospital bed bound, when I was just randomly on this little, I guess, sofa thing by the window, and my husband was sat in the hospital bed, so it kept throwing them off. But it wasn't that bad. I mean, the test tube, you have a chest tube. So when you wake up, you have that, which isn't pleasant in terms of whenever you need to go to the bathroom, you're carrying around like this suitcase that collects all this fluid from your lungs. So that was unpleasant. But I was up and walking within 24 hours, even though I had tons of tubes in me and IVs and everything. It was just a lot being connected to a lot of things. I was coughing a lot. But other than that, it really wasn't that bad in the hospital. It's when everything started to wear off when I got home is when the pain really started to kick in.
How long were you hospitalized for?
So my surgery was Wednesday morning and I was out by Saturday morning, which was a pretty quick turnaround.
Did they take the chest tube out?
Yes.
When was that?
I think that was on the Friday. I had a bit of an air leak. I don't know the scientific term of that, but I had an air leak. And the device I was connected to with the tube told them I had an air leak, but it sealed on its own, which meant that I didn't have to go home with any kind of device. Apparently, if it hadn't sealed, I would have had to go home with a device. I don't know if you can elaborate on that a little bit.
How about I give you the spiel that I would give to somebody who's having a lobectomy?
Yeah, this is going to be
so
nice.
It's a little bit different depending upon if I'm planning a minimally invasive surgery or if I'm planning an open operation with the bigger incision from the get-go. So usually what I tell people, and most of the time, like I said, we will at least try to do it in a minimally invasive fashion. So what that means is that you usually have 5 small incisions on your side. Some of them are about the size of my thumb, and then most of them are about the size of my pinky finger. One gets to be made a little bit bigger, and that's where we take the specimen out of your body, or the lobe or segment or wedge, whatever it is at the end of the case. Through that, I'm going to use small incisions, long instruments, a camera, and the surgical robot to take out whatever portion of your lung I need to remove. During the time of surgery, one of those incisions will get repurposed into a chest tube site. The chest tubes are about the size of my pinky finger, and they're kind of rigid. They do go in between the ribs on your side of surgery, and they're just uncomfortable. When you take a big, deep breath in, you'll kind of feel it and splint or take baby breaths around that being in there. And that's going to collect any fluid that's leaking from around the lung and any air bubbles. That's your air leak.
Okay.
And that's just when there's some air escaping from the cut surface of the lung. When we do lung surgery, we use surgical staplers, and those seal with staples on both sides and then cut in between. But if you have fragile lung tissue or if the dissection's difficult, sometimes you can end up with these tiny areas of your lung that are leaking air bubbles because the lung is like a sponge. And so that's what that tube is there for. And it has to stay in place until the volume of drainage is normal. That's usually about 200 or 300 milliliters a day. And make sure that it's not bloody, which it will look sort of bloody to somebody who's not a lung surgeon. But trust me, your team will tell you what is normal and what is not normal after lung surgery until all the bubbles are gone. Sometimes when you're in the hospital, your surgeons or your surgical team will come by and have you do weird things like cough a whole bunch of times or try and do this thing called a Valsalva where you increase your abdominal pressure. I tell people to blow on their thumb like they're playing a trumpet. And that's going to basically exert pressure on the cut surface of your lung and help us know if there's any ongoing air leak or not. As far as when the chest tube can come out, it's when the volume of drainage is normal and when all of the air bubbles are gone. And that's usually the limiting factor that keeps people in the hospital after lung surgery. So once the chest tube is safely removed, sometimes you can go home that same day and sometimes you go home the following day after that comes out. And that's taken out in your hospital room. You don't have to go back to the operating room or anything for that. It's done in your room with a series of breathing maneuvers. As far as the pain after thoracic surgery, it's super varied from person to person. I could do an identical operation on you and me, and we may report super different pain levels. So what we do here, and the practice is different at every institution, we perform a nerve block during the surgery if we're doing a minimally invasive surgery, which happens while you're still asleep. So hopefully that nerve block should be working when you wake up. Then we give you
nerve block.
Can
you explain what?
So the anesthesiologist and sometimes the surgeons, depending upon how it's done, they'll inject local anesthesia either in the nerves that run underneath your ribs or in a different type of nerve plane, but it should basically numb up the spaces where we did the surgery. That's the point of that.
Okay.
And usually those last for not a huge amount of time. The actual blocks last for about a day, less than a day, something like that. So it gets you over the initial hit of surgery. Then come the pain medicines. We give you anti-inflammatories, so Tylenol, ibuprofen. Sometimes we use a special extra strength IV type of ibuprofen called Toradol. And then nerve pain medication is very important after thoracic surgery. So here we use Lyrica, but Lyrica or gabapentin are very common neuropathic pain medications that we give patients. And that's again, because we always sort of bugger up those nerves between the ribs. And then conventional narcotics and sometimes muscle relaxants. So wherever you are, if you're somebody who has a pain of 1 or a pain score of 10, we figure out how to make it so that you can deep breathe and cough after lung surgery, because that is the most important thing to you recovering, getting your residual lung expanded and not getting a pneumonia after surgery. Super, super important to have good pain control. If I know that I'm doing a thoracotomy or the big incision for a lung cancer surgery, then I like to have the anesthesiologist put in an epidural in my patients before surgery, which is the same type of epidural catheter that pregnant women get when they have a baby, except it's several spaces higher. So instead of numbing you down here, it numbs your chest spaces on both sides. And that's a very effective form of pain control. But again, it's different surgeon to surgeon, institution to institution. I tell patients, and I would say that we should edge on the longer end of time in these situations in somebody who has had previous systemic therapy because of sometimes the stickiness. But I generally tell patients for lung resections, the surgery takes between 2 and 4 hours, sometimes a little bit longer. And then the recovery in the hospital is usually between 2 and 4 days, but that can also be longer if things are really challenging or if there are any complications. So that's my usual spiel.
And when you're talking about surgical complications, what does that look like?
So anytime you have a big surgery, there are always things that could potentially happen that are even unrelated to where you're working. So you could have things like a blood clot in your legs that goes to your pulmonary artery. That's called a PE. You can have things even like a heart attack or a stroke just related to anesthesia. Very, very rare, but things can happen. As far as thoracic surgery specific complications, I think about bleeding. That can happen. It's very rare, but it can happen. And that would require you to go back to the operating room and have that bleeding addressed. But honestly, the most common thing after thoracic surgery, which is super annoying for everyone, the patients specifically, but also us, the surgeons, because we want you to heal, is that persistent air leak. If the bubbles are still leaking from the cut surface of your lung, because what mostly heals that is time. And like you said, Samantha, you're not a patient person. Most surgeons you meet are not patient people either. And sometimes you're just in the hospital stuck there with that chest tube waiting for it to heal. Once it gets to a certain point in time, sometimes people will send you home with a chest tube, but we really try not to. So I would say that that's the biggest surgical complication that I, think of as a prolonged air leak. Or we take out the tube, and as it just so happens, that space, we missed that there was some small air leak. And so people get a pneumothorax that reaccumulates, or even fluid in the area that reaccumulates that would need another drain.
So that air leak causes air to come from the outside to the area around the lung, and then the lung can't inflate.
Yeah, so the little cut area of the lung, if it's still leaking air, those air bubbles will come out of the lung, and then there's space between your lung and your chest wall, and that space gets bigger, 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 and squishes your lung. And that can happen with air or fluid.
I see. And Samantha was talking about there are individuals who the location of their tumor can depend on if they're a candidate or this or not. What are the risks of certain locations that are risks we can't really tolerate?
So if somebody has a peripheral, meaning close to the outside of their lung, far away from the heart, those are the things that are easiest to remove. If the tumor is really, really close to the heart on the main pulmonary arteries, it becomes very challenging to remove. And I would say that patients who require the entire lung being taken out, that's a very, very high risk thing. Or if the tumor looks like it's growing into any of the main structures around the heart, like the main pulmonary artery or the pulmonary artery to one side of the lung, like the big one.
And the risk is cutting those arteries or
cutting them, having to reconstruct them, and then the risk of potential bleeding during surgery being a really big deal.
Yeah, and the arteries that run there, I mean, that's the primary output of the heart. So it's a high pressure system. I imagine nicking that can be fatal.
It could be, yes. Yeah. The pulmonary artery is actually, because it's, reverse of what we think of arteries and veins. So the pulmonary artery has the deoxygenated blood, and then the veins have the oxygenated blood. So the pulmonary artery is actually a relatively low flow system, but you're still super close to the heart, and they are large vessels. So you can lose a lot of blood very quickly.
All right. I was thinking of nicking the aorta, but this is why you're the surgeon and I'm not.
Hopefully I'm not operating on the aorta. If I was operating on the aorta, then I'd be a heart surgeon instead of a thoracic surgeon. And I had enough of that in my fellowship.
I had a little bit of that in med school, which was as much as I needed. Yeah. Anyway, but yeah, so those are the potential surgical risks. What about the post-surgical risks? Like, what is Samantha at risk for now as she's healing?
Well, you're still at risk for certain things like blood clots as you heal after a major surgery. That's one thing. And then I would say things like what we talked about, where fluid can accumulate in the chest space. Those are things that I look for. There's a risk of wound infection. That risk is lower in chest surgery than it is in abdominal surgery. Just makes sense. This is a less dirty area of the body than, say, if you were operating on a colon. Just less bacteria there. And then I would say chronic pain can be an issue for certain patients, especially if you have the bigger incision. It is a risk. And decreased lung function, needing oxygen after surgery. Again, you talked about, you live at altitude, I live at altitude. I think we send people home on oxygen more than if we were at sea level. But that's not necessarily a forever thing. In fact, in most of my patients, it's not a forever thing. Sometimes you just need some oxygen for a couple of weeks, and then we're able to discontinue that. So those are the major things that patients see.
And Samantha, you've mentioned your activity is increased now. You're up to hiking over 2 miles. How long were you pretty much unable to do that? And you're an active person, so I want to, for people listening, your baseline level of activity is really high. So how long were you kind of on the couch in the bed?
I mean, the day I got home from the hospital, I was walking the neighborhood, and I started off with just down the street. 5-6 minutes. I live in a townhome, so I have a massive flight of stairs. So it was like 5-6 minutes down the street, and then up the flight of stairs was enough for me. And then the next day was, well, can I make it to the communal mailbox and back without stopping? And so I've just set targets for myself each day to try and smash to feel like I'm achieving something. But, initially it was very much like baby steps around the neighborhood. And there have been some days where I felt like I've pushed myself too much, and I pay for it the next day in soreness. And so I've just learned to listen to my body and know when pushing too much is too much for me right now.
And what's the limitation? Is it the soreness? Is it hard to breathe? What do you feel?
It is honestly not really the breathing, because like I said, I had such limited function before. It's more the tiredness. And I just feel like I'm an 85-year-old trying to walk right now. I just feel like my body's super heavy. I'm a lot more fatigued. My body's just been through a lot. So forcing it to walk on a trail is a lot for my body right now.
Yeah, I think you're doing the right thing, and this is usually what we counsel patients to do, is push it a little bit, especially if you feel if you feel that fatigue, usually exercise is like one of the things that,
Yeah.
ironically helps. Is there any advice that you give patients when they're at home recovering?
Yeah, I would say, try and push yourself. And then when you get to a point where you feel like things really start to hurt, then stop.
Yeah.
There's no reason to take a step back. And then you can always divide up, you're an excellent trail hiker. Try and make things smaller.
Mhm.
So instead of 1 5-mile hike, okay, it's 9 o'clock, I'm going to go do a lap around my neighborhood or even my house. We counsel patients about doing laps around their house because you're not outside. It makes you feel super goofy doing laps around your house, but we want you to breathe and cough after the surgery. So anything you can do that's like a real accomplishable goal, that's what we want patients to do. Don't try and climb a mountain the day after you get home from lung surgery because you'll actually set yourself back a little bit.
Yeah. And I have a walking pad in my house, and I felt like that's been very helpful to me, that I do a 10 minutes here, 10 minutes there on the walking pad just to move, get my lungs breathing, get that cough, like you said, started. And that's helped me a lot mentally, just as much as physically, as just getting on that walking pad.
Well, and Samantha, before we kind of get ready to wrap up here, what last questions do you have for Allie, myself, the group?
I think you've answered everything, and I'm excited that there's another group of doctors who are willing to take us on.
Yeah, I think as we were mentioning, patient selection is really important for me as a medical oncologist. The things I think about are we need to have people whose tumors are responsive to these treatments that worked for a while.
Mm-hmm.
I think that was a big difference between before and now we're starting to get some data that these surgeries do make sense in patients who have tumors that respond really well to these targeted therapies, to other things. And more of those are coming out. So I think pushing the envelope more and more is going to make more sense.
Mm-hmm.
But I do think that that's probably a critical element. And you have a targetable mutation, Samantha. So I think particularly individuals who have targetable mutations in thoracic, that means EGFR, ALK, HER2, things like that. Those offer really good therapies that work for a long time if your tumor volume is low.
Mm-hmm.
So to be able to give those therapies, see what's left over, ask Allie if she can resect it.
Can we make this a chronic disease? Is what we're asking. That's kind of the goal here. I mean, I would love to say that we would cure people forever, and maybe that'll be something that's possible in the future. But when I'm thinking about surgical resections for stage 4 disease right now, I'm thinking, can we take out anything that the naked eye can really see, the naked PET scan eye, and can we make this like a chronic disease for this person?
Yeah, and then whatever's left over, I'll be giving therapies for throughout the whole body. And then, ideally, we're in a situation where if something does pop up later, if there's a lesion in the liver, if another lesion comes up in the lung, well, then we get to ask the same question again. Does it make sense to do a resection? Does it make sense to do a spot of radiation? And then I think that's the way, at least in the system we have right now, I think that is how we turn cancer into a chronic disease.
Mm-hmm.
Agree.
Okay. Well, I think that's as good a place to cut it as any. Thank you, everyone, for joining. This has been Cracking Cancer, and you can subscribe, and visit us at crackingcancer.org for more information. Thanks for joining.
Thanks for having me.
Thank you.
Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research, because together we can crack cancer.